Hi, I'm Dr. Jack Cush, Executive Editor of RheumNow.com, coming to you from EULAR 2018. This afternoon, I ended the day by going to a session by Georg, Schett, a really interesting session. It was about bench to bedside, and his particular lecture was called, "Does it matter to the clinician? Can pathophysiologic knowledge lead to better patient care?" Once he got over the shock of having to do that lecture, he sort of organized his thoughts around the concepts of pathophysiology, what we know about disease, and how it relates to psoriatic arthritis and risk in future therapy. It was a highly interesting session wherein he sort of laid out for us maybe some of the new thinking and how it could lead to some new changes in the management of psoriatic disease. First off, he talked about a biomarker. Everyone loves a biomarker, and he said that we should not lose sight of the fact that we have a biomarker in psoriatic arthritis, and it's called psoriasis, meaning those are the people who are at risk. And we just now need to know what are the risk factors that can lead to the development of psoriatic arthritis. First on his list was the idea of mechanical stress. He says that the psoriatic state, being at risk for psoriasis, whether it's genetically at risk or otherwise at risk, is influenced by physical stress, maybe leading to skin disease, but certainly leading to the articular manifestations, everything from the enthesitis, the synovitis, the spondylitis, even the nail disease is felt to be due to mechanical stress. And one of the key elements that underlies this, when one looks at the risk factors for developing psoriatic arthritis, many have been proposed, but one that you may not recognize is occupational heavy lifting. Is probably one of the only ones on the list that he showed us that was in fact significant, suggesting that especially in males, becomes a significant risk factor. So he went through this basically stating that there's obviously a preclinical phase where people can become at risk, that there are risk factors like the usual ones, obesity and lifestyle such as smoking, etc. But that can lead to, along with this mechanical stress, lead to immunologic activation. In fact, he supports that by showing data of psoriatic arthritis patients who stop their DMARD therapies and what is the risk for relapse of disease after one has stopped taking the drugs. And it turns out that those who are at greatest risk, and by far and away way above the comparator group, were males. Males were at great risk for recurrence of their disease and for flares, much more so than women. So that's important to take note of. The early recognition is obviously an important part, and that may be because of the threshold for identification is different, in that skin's easy to see, joints not so much. So there is an early threshold that one has to go through. But that all becomes important and leads to factors such as nail disease. And nail disease is, as we know, a risk factor for developing psoriatic arthritis, but that's part of that mechanical stress that needs to be present, that leads to an increased risk of the disease. Turns out that when you look for evidence of enthesitis, another sign of mechanical stress, this also becomes something that portends the onset of disease. And if you look at those who have abnormal MRIs or abnormal ultrasounds as features of mechanical stress, it looks like that too predicts the disease. So it is a systemic disease. It is one that needs to be controlled. It is not driven by IL-6 and CRP. Instead, it seems to be largely driven by IL-23 and IL-17 and possibly IL-12. And you know, he used his bedside to bench slide that actually shows that really, really well. IL-17 obviously is a key player, and therefore why it is a new target in developing disease. He made a point that in addition to the enthesopathy, there's the arthritis, but often the arthritis is overstated in clinical trials. That in practice, it's probably a lot fewer joints that are involved. The oligoarticular disease, asymmetric polyarticular disease, is far more common than the very polyarticular patients who are enrolled in trials. And enthesopathy is often involved in practice and may not often be appreciated. And so what has been seen is that the more interesting new data is that IL-23, whether individually like guselkumab or in combination with 12/23 inhibition, really hasn't fared all that well when it comes to managing things like axial disease and enthesitis and whatnot. So enthesitis responds more like the skin than the joints in some trials that were shown, especially with ustekinumab. So that's an interesting factor that he presented. He's going forward looking at fingerprinting patients, developing profiles of gene expression that may be important in identifying those at risk. So again, what makes this an unusual disease is the combination of enthesitis and synovitis and its effect on growing new bone. But the disease needs to be considered maybe in a different manner, that there may be risk which can be modified by lifestyle, and then immunology which can be modified by therapeutics. So lifestyle would be avoiding mechanical stress, avoiding obesity and smoking, and then dealing with some of the magnifiers of disease in the comorbidities, whether it's managing hyperuricemia, cardiovascular risk, or depression. These are a lot of the concepts that were covered. It was a very stimulating, intellectually stimulating a session run by Professor Georg Schett. We want to thank him for that. That's it. Tuning in from EULAR and Amsterdam. Enjoy Room Now.